Negative.
Okay, it's a negative infarct imaging agent. So if you're using thallium or any of your perfusion imaging agents, that's going to produce a negative.
Okay, yeah.
How
do you tell?
Hey, scoot up.
Okay, negative means that there's an absence of activity. Positive means that there's an increase in activity.
Absence of that. I'm sorry, one more time.
Okay, if there's an absence of activity, then it's a negative infarct imaging agent. Okay, because it's showing that there's no blood flow or no activity in that area.
It's negative.
Yeah. The positive ones.
So the black part wasn't the activity?
Well, the black part is the absence of activity.
Okay, I see what you mean.
Yeah, so any area where there's radiopharmaceutical, it's going to have color. Any area where the count rate is low, you'll have an absence of activity. Some of the doctors, I think there's some, let me just take a look at some of the stuff here.
So is it positive would show a hot spot then?
If it's positive, it would show a hot spot. So that's pyrophosphate, or, now like I said, I don't think we've ever had 111-indium antimycin in this country. I've never seen it. But some people like these color displays. And on these color displays, you need to have what's the word I'm looking for? A code that tells you what each color represents. You know, so like if red is 100 counts per pixel, then in this particular case you might have where every change of 20% results in a different color. So you know, like red might be 100%, orange might be 80%, yellow might be 60%. So for every 20% change you have, the computer assigns a different color. Okay, so some doctors like it, you know, presented in that matter here, because like they're saying, okay, well, you know, we have 100% here. What part of the heart is this? Okay, this is the lateral wall. So we've got a lateral wall area here. We've got maybe 100% in this part. We've got 80% where the yellow is. But then you got green, which might be 60. Okay, so it's telling you. And then you got over here the blue color, which you know, probably that's really bad. You know, it's telling you that you have, yeah, it's the septum and the apex are not getting perfused at all compared to the rest of the heart. Okay. Then in some of the other stuff that they want you to be aware of, or what I would like you to be aware of. Okay, these are the positive infarct imaging agents. Okay, normally if I add the technetium to the pyrophosphate, so it's no longer just a cold kit, I inject it into the patient. We know that pyrophosphate originally was a bone scanning agent. That's what it was first designed for. So in this particular case here, we see the sternum, we see the ribs. We don't see any activity where the heart is. So this would be a normal study. But normally what they do when they're trying to determine whether or not there's an infarct, they compare the activity in the sternum and the ribs to the activity that's in the heart. It's like on this one down here. Okay, now this is a dual intensity study here. And they're calling it normal because they're saying that the activity here in the bone is more than the activity that's here in the heart. Does that make sense? They normally have a grading system from 0 to +4. So +4 means, you know, definite. You definitely have an infarct. But again, they're just comparing the activity in the bone to the activity in the heart. Okay, I don't know. I would be a little bit concerned about this, but I've seen some patients with congestive heart failure and, you know, poor renal function. So there's still activity left in the blood. So that means that it's still in circulation. But a positive study here, now I think I've got some better ones than this. So here you see the activity here is more or equal to that in the bone. So this is a positive infarct study here. And again, typically you know, the best time to image these patients, okay, you can't image them right away. So if I'm complaining of chest pain right now, and you do a pyrophosphate study on me, it's normal. You wait 24 to 48 hours, and then it's going to start being abnormal. And one of the reasons why is because the mitochondria in the muscle, when they die, they take in calcium as part of the scar tissue development process. So that's why you're seeing it here. This is actually dead mitochondria that are starting to be calcified as part of preparing scar tissue. But like I said, the scar tissue is the same stuff that bulges out on a MUGA study, which would give us an abnormal phase analysis.
So the pyrophosphate's only useful like 2 to 14 days after?
Yeah, once the scar tissue is completely, you know, done repairing itself, then it's going to be normal again. Okay. But some of the other stuff that I also want you to be aware of is the quality control of the SPECT images. Okay, and I also sent you, there's a section in this the nuclear cardiology book. I think it's section 25 or something like that. 25 is drugs. I sent you that one too. On the one chapter that I sent you here, okay, it reminds you of how important it is to do all your quality control testing of your gamma camera before you start doing any patients. You really wouldn't want to do a whole day of patients and then, you know, the next day you discover when you do the quality control that you have a bad PM tube or something. Okay. On this one over here, okay, what do you think is going on with this one? And first of all, do you guys see a defect anywhere?
The anterior wall, yeah.
Okay, what would be a cause of that? It looks a little bit weird to me.
Yeah. Could it be attenuation from the breast or something?
Very good, that's exactly what it is. Okay. Breast attenuation is mainly going to affect the anterior wall. Okay, so how do you correct that?
Compression?
Huh?
Imaging.
Okay, what would you do to the patient to handle that problem? Prone. Okay, very good. Prone. Okay, so that's what a lot of facilities do, is they'll do prone imaging to get rid of that, or to make sure that that isn't what the problem is. Okay, because yeah, we don't know. Is that a defect? Does this patient? If I have a defect on the stress and a defect on the rest, what would that normally be diagnosed as? Okay, defect on the stress and a defect on the rest. What type of a diagnosis would that be? Okay, irreversible or an infarct. More than likely it's an infarct. Now remember, there's also what they call stunned myocardium. Okay, so when the heart has been injured, sometimes it's kind of like in a hibernating phase until it'll start slowly recovering. Okay, so a lot of times that's when they use thallium, because they can do delayed imaging on the thallium, and you know it'll start picking up the stuff. Okay.
It's hibernating myocardium.
What's that?
Hibernating myocardium.
Yeah. This is another thing here.
What is it?
Oh, it's tissue that's been stressed, stunned. You know, it's, you know, it's had its blood supply cut off and it's just kind of coming back online. You know, it's like you get hit in the head and you're sort of like, you know, not able to react. You see stars for a while. It takes a while for your head to come back. Okay. The other thing though is attenuation correction, and you know, basically, I don't know if you can see the difference between these two images, but we have all this garbage over here, and then over here with attenuation correction, we kind of get, you know, make it a little bit more realistic of what's going on here.
So if it's bad on rest and it's good on stress, that's
Ischemia.
ischemia, and what if it's the other way around?
That doesn't happen. The only time that would happen is if you screwed up. And by that, okay, what sometimes happens is you do a stress test, you inject the patient, and it infiltrates. Okay? And you still do the imaging. And especially it happens when you do thallium. Okay? So what happens with thallium is that, you know, the patient comes back 4 hours later, and you actually have more, you know, a lot more perfusion than you had when you first did the initial part of the study. Okay, and even one of the quality control tests that you're supposed to do for sestimity, you know, you're supposed to have like 10 millicuries for the first phase and then 30 millicuries if you did the same day protocol. You're actually supposed to like draw a region of interest around your composite image, you know, for you know, when you're assigning like where the apex is and everything. You're supposed to measure the number of counts, and I should have 3 times more counts in the second set of pictures than in the first set of pictures. Does that make sense?
Because the
So-
dose more.
Yeah. So if I don't, that means that part of my dose didn't get to the heart. So it's just a comparison type of thing. This is another problem that you run into once in a while. Book tearing on you. These books are really cheap. Okay, sometimes you'll see something in the inferior wall. Okay, and that's diaphragm attenuation. Okay. And notice it says the patient lying prone. That also helps get rid of diaphragm attenuation. Yeah, here's one up here too. Up here, just a little bit less activity, and then what's wrong with this one?
About
Bowel or liver.
Yeah, okay, that's exactly right. So in this case here, what would you have done?
Water.
Yeah, give the patient water to drink. So up here is the first series of pictures, and then down here is after they've given the patient some water, and notice that it's flushed everything out. Okay? I think most people just routinely do that, give the patient water before they start imaging. Why does that happen?
help to bring the bowels down. Cavity.
Why do we have activity there in the first place?
Fatty acid goes through the liver and that.
Right, yeah, remember that sestimity and all of your technetium compounds are sort of fatty acid based, and that's why when they get taken up by the myocardium, they never leave. There's no like washout or anything like that. It's also excreted out through the liver, and that's why it goes into the gallbladder and things like that. Might even get a double charge if you want. Charge the patient for a gallbladder study and the sestimity. But again, that's another thing. Then the other thing that we talked about was motion. Okay, and normally on motion, remember this thing should look like a horseshoe. Okay, so here's the stress images here, here's the rest images. Which one has the motion? The stress or the rest? looking for motion, and so one of these pictures is very good. This is the stress, and this is the rest. Okay. So my question is, which one has the motion?
Rest.
Yeah, the rest one. Because you see how it's not aligning. You have an incomplete reverse letter U here, or did we say it was an upside down B? I don't remember. Upside down U or an upside down
Wouldn't that
B?
just be indicating ischemia?
Well, you normally you wouldn't have a reverse like that, right? Normally you shouldn't have it where you have a normal stress and an abnormal rest. That should not happen. You know, physiologically, that shouldn't happen. The only time that would happen is if you had a misadministration, you know, or not a misadministration, but you had an infiltration. Okay. But normally what it would, so it said that if you have a misalignment, okay, that's a clue that your patient probably moved on you. Okay, the other thing is this, okay, you guys are supposed to look at the image reconstruction, you know, the dynamic mode on the cine display. How many of you guys do that? Now, you know what you're looking for, or say, oh, that's pretty cool.
Looking for jumping.
Y-axis.
Yeah. Okay, so now normally you tell the computer to acquire a certain number of slices. Remember those slices that we use to create the polar image? So there's about like 13 slices. Okay, so here's slice number 1, 2, 3, 4, 5, 6, 7. Here's 8 slices that were reconstructed. We're not showing the very first, which would be like the apex. You know, normally it starts with the apex, works its way through the heart to the base. So each one of these images is a different reconstruction of a different area of the heart. It should be a straight line. Okay, so this frame here is where the patient moved on. You know, maybe their arm got tired of being in a certain position, but something happened and they moved. Okay, does that make sense? Okay. The other thing you can look for is what they call the hurricane sign. Okay. So you've all seen whenever there's a hurricane coming in, okay, we have this type of a thing here. And what I'm going to try to do, you know, on the quiz that I'm going to give you next week over the cardiac, I'll put something like this here, and I will ask you, what type of a problem does this most likely represent?
Is that the short axis, or is there something?
That's a short axis view.
Um,
Yeah. Normally, all of your other images are based off of the short axis. So that's what we acquire first. And then we reorientate that Fourier transform. Remember, basically this is just a series of frequencies that were transmitted to your computer. And when we reorient them, that's how we're able to get the vertical and the horizontal long axis views. But basically what you're looking for here, like we said, is it should be a nice round circle and not have those little things on it. What's another test we can do for to make sure that the patient didn't move?
Histogram.
No?
Can we look at that if there's any
glitches.
It's not called a histogram though.
sinogram?
Sinogram. Yeah, a lot of people look at this one first because this is, okay, this is what it should look like. One continuous amount of activity. So if the patient moves, you'll see breaks in it. Okay. So the patient did move on that.
I saw the motion correction software, they work very good.
Yeah. Well.
But they're expensive though.
Yeah. Yeah, they're not gonna, you know, motion correction is, you know, your options are either you redo the test, or you use the motion correction software.
Like at Kaiser, the tech told the patient not to move or snore, sleep, or talk and stuff because we can see the motion. But at my hospital, they just talk by nothing. Like the patient talk to the family, and you know, they move, they scratch their legs and stuff like.
Well, you know, you guys, here, this is where it comes down to you. Okay, who is ultimately responsible for the control? Okay, you're the ones that control what goes on in the imaging room. You've got a patient full of radiation, and these people